Thank you, Dr. Sushmita, and thank you for including me into this program. Mix before you rush in, what not to do. The first thing you have to do, not to do, is don't rush in. You don't have to rush in. So if your indication is that other people are doing MIG and I must do it also, so that should not be the indication, because there are alternatives, and you have SLT medicines, traps, tubes, and we have been doing them and managing these patients with these methods for so long, and they are still valid. However, some patients are likely to benefit from mix. So important thing is to identify those patients, and those are the reasons where you could consider doing mix, learn these mix and offer them to your patients. Second thing is that MIGs are not for every patient. For advanced glaucoma, they are not recommended. Avoid MIGs in advanced glaucoma cases where the visual field, there is a severe visual field loss, because MIGs are unlikely to meet target IOP in those conditions where the requirements are low. MIGs are indicated basically for mild to moderate disease or ocular hypertension where you want to treat. Another thing you have to keep in mind is the risk of bleeding. So if your patient is the one where the risk of bleeding is higher, you have to be careful in doing mix. Patient anticoagulation therapy long term, or other hematological disorders where you have higher risk of bleeding, you have to avoid mix or control it nicely before doing mix. And also if you have a vascularization of the anterior segment, iris or angle, you can't do mix in those cases because there will be a bleeding, which is the commonest complication with the mix anyway. Avoid mix when there's an extensive peripheral anterior synecdoche, and also especially if there's an inflammatory conditions of the eye, if you have a uveitis, chronic uveitis, and there's a lot of synecdoche already. I think those are not the cases of the mix, because even if you do a successful MIG, it might actually close later because of the ongoing synechial inflammation, which will lead to more synecdoche formation. Important thing is, if you're not familiar with the procedure, I think you have to be familiar before you do mix. So you need a microscope which can be tilted. You need to turn the patient's head to the opposite side, and since you are operating on the temporal side, sitting on the temporal side, so the position of the microscope, your surgeon's position may be a little awkward for you in the beginning. So it's very important to get familiar with the operating room setup, the procedure, and before you actually start doing any mix surgery. Proficiency in intraoperative gonioscopy very important. It's like you don't dive into the pool unless you know swimming, and gonioscopy is something like that, because that's very, very basic. Unless you are expert in swimming or good in swimming, in gonioscopy, you can't really do mix. So you have to learn gonioscopy in the clinics, and also direct gonioscope in the operating room before you can do mix. Then if the angle view is poor for any reason, you should not be attempting mix. And then important thing is train yourself. So attend some workshops, wet labs, observe other people doing it, and do under guidance a few procedures before you can start doing them independently. Another important thing is the patient understanding and cooperation is very important. So if you have a patient which doesn't understand what you're doing, that's true for all glaucoma surgeries, but especially true for a mix, because some of them are very expensive, and the desired outcome may not be to patient's satisfaction. So you have to explain them to very carefully. And if you're doing it topical, then the patient cooperation would be needed. So it's better to start with with some anesthesia, maybe perivulvar or retrovulvar or some other. But you can potentially do them under topical anesthesia, but then the patient has to understand what is being done. And most importantly and lastly, the patient's safety is very important, and you have to consider the procedure in relation to the patient's clinical characteristics. And this was the patient we did GAT, and you can see there's a bit of hyphema there, and it doesn't look much, but the patient came with a pressure of 55 millimeters of mercury the next day. And if you have a disc which is already damaged, that much pressure could actually compromise the visual field and visual performance later on. So hyphema is the commonest complication. Most of the time it's not of much consequence, but once in a while you can get very high pressures, and that could be detrimental to the patient's vision. So thank you very much. That's all in 5 minutes. Thank you.